BRAF V600E, again, is one of the many BRAF mutations that we can detect. As many of you are aware, these mutations are also found in patients with melanoma. The biology of BRAF mutation at this point suggests that there are 3 separate classes of these mutations that I'm not really go into the details of these classes, but the BRAF V600E is considered to be a class 1 mutation. These are activating mutations for the most part. And under the category of BRAF mutation, the literature suggests that about half of these fall under the category of V600E, meaning that there are other potential mutations under this category that could have a differential response to various treatments. For this particular V600E, again, as you saw in the case, based on multiple published reports, the combination of the BRAF and trametinib has become our standard of care because of the efficacy and the clinical activity and also tolerability of this particular combination. We did start trials with single agent BRAF inhibitors. However, the literature does show that a combination of a MEK inhibitor plus a BRAF inhibitor can actually improve not just the response rates, but survival and PFS of patients who are being treated with this particular combination. And that's why that has become the standard of care for patients who can tolerate it as opposed to single agent drug. Keep in mind that much like what we have learned from the world of EGFR and even ALK, patients who are treated with these targeted therapies, unfortunately, eventually do develop resistant mechanisms, and there's a lot of work going on to better define the nature of these resistant mechanisms. But again, I think it's good to sort of very quickly review that BRAF sits in a signaling pathway that allows these cancer cells to basically bypass a particular block and be able to move into a different direction, and that's how cancers can basically progress. This also highlights the fact that many of these patients, once they have any evidence of progression, should undergo repeat biopsies to see if other potential mechanism of resistance can be found, because again, for some of these new resistant mechanisms, we might be able to have specific clinical trials with targeted therapies to sort of establish the role of new potential treatments for patients who are progressing on frontline double therapy, as we discussed here.